Yeah, so what I'm going to give you is just a short talk. It's not about any research I've done. It's probably more just like problematizing some of the things I've been thinking about when it comes to including linguistic minority experiences in health communication. And I'd like to thank Susie McQueen, who has had some input into my thoughts on this. So the first thing, yeah, so looking at the literature, I had a quick look at kind of the most recent literature on health communication and health literacy. And the first thing, the first thing that stands out is the number of different terms that get used. You've probably heard a lot of these before, and there's lots of nuance. Like it's not always clear or specific who falls under each of these names, these terms. For example, with the cowed term that gets used a lot these days, it's quite vague who is included in this term. Like, for example, I'm a migrant. I'm conversant in English. I'm quite been in Australia a long time, so I'm quite used to the health system. On the other hand, I might be on the receiving end of some kind of different treatment or discrimination when I go into the health context. So how do I fit under this term? So some researchers have said one of the things we need to do if we're going to address health equity and health disparity, we need to be really clear about the categories that we use to identify different minority groups. And then that will allow for comparison between different research studies. The other thing is we need to account for, not all those groups are, of course, very clear cut. We've got mixed race, as well, that needs to be accounted for. Yeah, and we need to think about not only who is a minority, but what is their proficiency in English in the Australian context, and who is most likely to be on the receiving end of discrimination or racism. Okay, so now I'm probably going to repeat some of the things that Toon has already said. Right, so here's some of the main points that come out of the research on health communication. So there's a lot of concerns about health equity. Research has found there is more misunderstanding, less compliance, less satisfaction in intercultural medical consultations than there is in intracultural medical consultations. It's been found that ethnic minority patients are less likely to be recommended for certain treatments than white patients. In the Australian context, Aboriginal patients have fewer opportunities to initiate a topic with their doctor, and the doctor tends to determine the conversational direction of the consultation. And another finding is about rapport building and responsiveness towards patients' offers. It's been found to be lower in consultations with ethnic minority patients compared to white patients. So I'll just give you a quick, sorry. This is just a very quick summary of some of the issues that come out in the literature. So the big one is improving health communication for equity requires changes at the systemic level. So we need to interrogate the assumptions that are made about the language skills and the competency of patients who are not of an Anglo background in the Australian context. And it's not just about a language barrier. We need to look at communication styles. So there might be cultural differences in the way that people communicate, especially in a health setting. The way that ill health and treatment are perceived can vary between different cultures, and the way decisions are made, whether shared decision-making or individualized decision-making is more common in different groups. And so that takes us to interpreters. That's why researchers argue that sometimes you don't just need a professional medical interpreter or a family interpreter. What might be best is to draw on both of those in a medical consultation, because they both offer different purposes for the patient. And also, ideally, we'd have language concordant health services. That's been discussed by Antoon. On the training and education side, there's a lack of targeted training for health professionals. And this also extends to cultural competency training in the education context. So for undergraduate and graduate health trainees, what that could do is to help address this institutionalized systemic discrimination that's happening. And when it comes to the literature on health literacy, we can see that poor literacy and numeracy skills also translates to low health literacy. So they're very closely connected. And it's also closely connected to lack of digital access, to issues with printed health materials and even e-information that we think is more progressive. For people who are unfamiliar with the health system, if they're new arrivals to a country, they need to get familiar with that, and they might have a lack of formal and informal support networks to assist with that. So now I'm just going to quickly touch on a project that we're starting to work on here at ICH. In conjunction with a whole bunch of partners, including Peter Schultz, who's here, and Rosemary Saunders. And this is to look at heart failure patients, chronic disease, and how we can improve their health literacy. One of the findings about heart failure is that it is patients who are from a minority language background and they have heart failure have a higher chance of rehospitalization and ED visitation. So it's important as we start this project that we try to include these patients in our methodology. And this is where some of the challenges are coming up in how we think about participant recruitment. So, sorry, this is really not good. So yeah, when we think about recruiting and retaining individuals from minority ethnic groups, I turn to the UK, the NIHR, the National Institute for Health and Research, and their Include project, which basically has 4 recommendations for how we can be more inclusive. And they are to ensure that your eligibility criteria is inclusive, it doesn't exclude people inadvertently, to make sure that your trial materials are developed with inclusion in mind, to make sure your research staff are culturally competent, and to build trusting partnerships with community organisations. So these recommendations sound pretty straightforward, but what we're finding with our study is how normative standard research methods, things that we accept as normative in the university research space, and the kind of institutional restrictions that are placed upon funding and how we deliver research can get in the way of reaching some of these goals. So just as an example, for example, in our study on health literacy, it's a standard exclusion criteria in a lot of health services research that if the participant needs an interpreter, then we exclude them from the study. Well, one, that can be costly. We might not have the budget for it. 2, it makes the data collection process more complex. So we're trying to simplify things. And thirdly, we question, how can we accurately measure health literacy if there's a third party involved? So that's a little complex problem there. Then the consent process, as you know, a lot of health research, you've got to read a 4-page participant information sheet. Even though ethics requires you to do it in plain language, it can still be wordy. It can contain lots of conditional clauses, like what if something happens, there's a possible risk this might happen, but it's unlikely. So that kind of complex language might be hard to navigate. And one of the big challenges for us is that we wanted to create this really comprehensive health literacy survey. So we wanted to account for social determinants of health, the patient's level of empowerment, their knowledge of heart failure. But in doing this, and we made the font really big so that it's easy for them to read, but in doing this, the survey becomes 18 pages long. And so now we worry, like, are we going to have a high attrition rate? And if their English is limited, are they just going to drop out straight away? How are we going to hold on to these people? So it's like this wicked problem. How do we capture? We want to improve health literacy, but how are we going to make sure we retain the low health literacy participants? And so one of the things that Susie and I talked about is, well, maybe we need to come up with a separate process. If this quantitative measurement tool excludes some of the patients we're trying to target, can we capture them in an alternate process where we interview them and ask them about the barriers they're facing in their management of heart failure? Okay, I think I'm out of time, but I just wanted to say some positive things that are happening. We've got lots of more representation and advocacy and consumer reference groups that represent minority health consumers. We've got tools coming out of the NIHR, that help us to assess the equality impact of our research. And lastly, I just wanted to acknowledge John Viana, who's here in the audience, because he's from ANU's Responsible Innovation Lab, and they're looking also at how do we promote inclusive health research. Thank you, everybody.